We just at 2 o'clock, so we can go ahead and I can start introducing, and I'm sure we will have additional people joining here during the time. So, all right, welcome everyone to our MPRINT webinar series. Today we have Dr. William Jusko from SUNY Buffalo presenting on the application of a minimum PBPK model to meta-assessment of dexamethasone and betamethasone during pregnancy. Dr. Jusko is the SUNY Distinguished Professor of Pharmaceutical Sciences at the State University of New York at Buffalo, and has received numerous awards over his distinguished career, including the Oscar Hunter Career Award in Therapeutics from ASCPT, the AAPS Distinguished Pharmaceutical Sciences Award in 2020, and a number of other prestigious awards. So today he's going to present on some of the work he's done with corticosteroids in pregnancy. And Bill, will turn the talk to you. Thank you.
Thank you, Sarah, and hello, everyone. I'm very pleased to be able to give this webinar. Dexamethasone is a very frequently administered corticosteroid. It gained a lot of publicity during the ongoing COVID epidemic, in that it was the primary steroid used to suppress the cytokine storm that occurred in many patients. It's also a commonly used anti-inflammatory and immunosuppressive drug. Betamethasone is used much less. It's an epimer. It's almost identical structure to dexamethasone, but it's primarily used in racehorses. But as I'll talk about today, it's used during pregnancy when there is the threat of a premature delivery. It's used to induce surfactant to prevent respiratory distress syndrome in the babies after they're born. So my presentation has three components. The first is I'm going to introduce and talk about minimal PBPK models and how useful they can be in meta-analysis and species scaling. Then I'm going to give you some properties of dexamethasone and betamethasone, how we've assessed its kinetics in various species and in the PK/PD in non-pregnant woman. And then I'll get to the main point of today's session, dealing with our characterization of Dex and Beta PK in term pregnant women and their fetuses using our modeling approach. This work was supported both by the NIH and the Gates Foundation. Gates Foundation, as I'll show, is interested in better ways of treating women in low resource countries. And the hope was that our information could augment knowledge and provide better guidelines for use of these steroids under such circumstances. Okay, pharmacokinetics perspective. You see some data at the top right, concentration versus time profiles. There's various perspectives in considering such pharmacokinetic data. Of course, the drug concentration time course is what we see, but of course, we would like to appreciate how the data relates to the anatomy and physiology of the subjects, and also take into account the physicochemical and metabolic properties of the drug. Well, full PBPK models can do this, especially if they are studied and applied in animals where all possible information can be obtained. But in their application to humans, one makes a lot of assumptions, as I'll show. But our basic question is, how can you best analyze PK profiles if you only have plasma concentration versus time data? It's what we call a top-down approach. When we have such data, what can we do? But one approach is to apply compartmental models. You see one at the left, 3-compartment model, and it can be applied to the kind of PK data that we see. But there's a lot of questions about compartmental models. what's happening in the early distribution phase? What does distribution clearance mean? How do we deal with various sites of clearance? There's 3 volumes. What do they mean? And it's shown at the bottom. There are multiple parameters. How do we connect them to covariates? The last part involves population modeling. And there's actually quite a large industry that's evolved because of the complexities in connecting the PK parameters with a wide variety of possible variables that can be captured in doing studies in subjects. An indication of the difference between compartmental and PBPK modeling approaches is what happens soon after dosing the drug. So we have a concentration versus time profile like I show here. A compartmental model will use dose divided by the central volume as the starting point of the curve. A minimal and full PBPK model often will use dose divided by the volume of the blood in the subject. And you can see that can theoretically produce marked differences in the early time course. In turn, that's going to change everything in the way one interprets pharmacokinetics. It'll change distribution rates, area to the curve, have influences on later phases, and what one interprets for tissue concentrations. So there's a bit of an issue. Well, full PBPK models are the ultimate in pharmacokinetic data analysis. As most of you probably appreciate, what it typically involves is dividing the body according to tissues and organs, accounting for blood flow in and out of those organs, bringing into the proper anatomy, how things go in sequence, and basically constructing what will be a very complicated mathematical array of equations that one uses to characterize what's happening in every measured or assumed tissue in the body. Well, when that's done in animals, it provides tremendous insight into the properties of a drug. But when it's applied to humans, we have some issues. Animal data are based on real tissue measurements. Human KP values usually come from prediction methods that were originally based on rat data, and as I'll show, they differ from each other, are only roughly approximate. What happens with human PBPK models is they're often optimized by adjusting clearances until the plasma profiles fit. So it's basically based on how well plasma data fit, and that's what we do in all of pharmacokinetics. Presence of transporters adds uncertainties, and commercial PBPK models are based on the well-stirred organ model, and then sometimes there's better approaches. Lastly, full predictive PBPK models offer a lot of computational complexity with limited verifiability. So predicting KP, there are 3 or 4 methods that are commonly used, and the simulations plus software indicates how well each of these work. What's shown on the graph is the calculated, what you would get from the program, versus the experimental, what was originally done in rats, KP values, tissue plasma ratios. And one can see there's a lot of differences among these different prediction methods. The most commonly used one is the Rogers and Rowland method at the bottom left. And looking at that method, we can see that there's a lot of times where the predictions will work pretty good. And there's a lot of times when the ratios are far off. So how do you know ahead of time whether you're going to get a good prediction or not? No one ever measures tissue concentrations in humans to verify these kinds of predictions. So while full PBPK models are fantastic, when the data support them, there are some concerns. And essentially what goes on is we measure blood or plasma concentrations, but the human predictive models have this gray oval. So but you've heard of a black box. this gray oval basically means that there's some certainties what happens in the tissues, and there's some uncertainties. And basically, human tissue pharmacokinetics is typically assumed and unverified. So it leaves us to minimal models. So can we do something easier than applying a full model? So what happens with minimal models is we recognize that it's possible to lump tissues in the body into 2 or 3 groups. Sometimes they're lumped according to highly perfused and poorly perfused, sometimes based on size, sometimes based on permeability. But basically, we can simplify the complexity of the full model into the basic model that you see on the right. So this is showing 3 compartments, blood, and 2 tissue compartments, basically lumping all the tissues of the body into 2 major compartments. The model is structured just like a full model with blood flow coming in and out. There's some additional parameters that I'll show you. So the basic minimal model is shown here, and we have some physiological structures and restrictions. So we basically say that the 3 compartments add up to body weight. We put in cardiac output specific for each species. We use the actual blood volumes that can be estimated for any species. And we use the model to estimate KP values, tissue plasma ratios, and FD values, fractional distribution, into the 2 types of tissue compartments. So we seek 4 parameters from operating these models. They're listed at the top right. FD, B1, KP, clearance. The structure of the model is shown with equations that look just like the equations we use for full PBPK models. An equation for the plasma or blood compartment, and an equation for the 2 tissue compartments. So those who recognize full PBPK models will easily operate these equations. Part of the idea of these equations is to get a more physiological perspective on parameters that are needed to operate the model. And when we use compartmental models, we can estimate the distribution clearance. These models give us the same possibility, but with a better approach because of the better structure of the model. So distribution clearance represents the combination of the roles of permeability and blood flow. And our models estimate an FD value. It's a fraction of cardiac output that is going to each of the tissue compartments. As a fraction, it's dimensionless. That makes it easier for fitting data. So let me show a couple of applications in allometric scaling. So we found some data on moxifloxacin, an antibiotic. 5 species of data. You see what we did for built-in scaling of the model. Blood volume for each species, cardiac output scaled to body weight, clearance was allometrically scaled, and we knew body weight, we knew plasma volume, so the remaining tissue volume was that other fraction. So some parameters are independent of species, KP, FD, FR, and what we estimated in fitting the data are shown at the bottom. But look at the data. PK profiles for the drug in 5 different species, the minimal model with the built-in physiology and anatomy allowed fitting of an allometric clearance and capture the data extremely well. So we've done this many times. Another example is with dexamethasone. Dexamethasone, because it's used as an anti-inflammatory in all of veterinary medicine, it's been studied in many different species as you see on the graph. So we took the reported clearance from all of the publications that we could find. And this graph is showing an allometric graph, clearance versus body weight. You see the data points fall nicely on a regression line. The power coefficient is 0.87. Basically, dexamethasone scales classically according to the allometric body weight relationship that you see. We then sought to characterize the time course of plasma concentrations in all of these species. That's not something allometric scaling commonly can do, but it can be done with a minimal model. So what you see on the graph is the application of the basic minimal model that I've been showing. We're fitting the digitized data from publications for the 11 species. And what we found is, as I just showed you, clearances scale allometrically, but the tissue distribution properties were conserved across species. So what that means is the blood flow, organ size, permeability, partitioning, everything pertinent to dexamethasone is about the same in all species, but clearance differs according to common expectations with body weight. We've also done full PBPK modeling for dexamethasone in rats. Rats and sometimes mice are the most common species. We give the drug at various times, measure plasma, blood, tissue concentrations, and the model that we applied is seen on the graph. So PBPK modeling worked nicely for dexamethasone, but dexamethasone had some properties that may not be recognized unless one has done a study like this. For example, dexamethasone is subject to a transporter in the brain. We could include that with our measurements. There was some unusual distribution into fat. And of course, during pregnancy, as you'll see, dexamethasone is subject to a transporter movement across the placenta back to the mother. So a full PBPK model is possible for DEX. It confirms our other modeling and gives us a lot of insight into handling dexamethasone, no matter what the species. So to summarize minimal models, they're a top-down approach. It allows one to characterize plasma data with an assumed tissue structure. The tissue structure resembles that of full PBPK models, but lumps organs and tissues into the major categories, the two parts of the body weight, V1 and V2. So a full PBPK mechanism-based model is a bottom-up approach, but sometimes not fully supported by rich data like I showed in the rats. So now let me get into the corticosteroids. Some of the common administered ones are shown on the graph. These are the master hormones of the body, or cortisol is. They regulate development, metabolism, immune responses. Produced by the adrenal cortex, there's glucocorticoid receptors in almost all tissues in the body, and steroids binding to these receptors have a variety of types of effects. So the types of effects that you see are in the diagram on the right. They will induce lung maturation, which is the subject of this presentation, but they have effects on a variety of other tissues. Most of those effects are negative. Changes in protein, fat, carbohydrate metabolism, changes in body structure. So the steroids have potent immunosuppressive and anti-inflammatory effects, but they have to be dosed judiciously. That's sometimes a problem in giving the steroids to a pregnant woman, and part of the reason for the pursuit of our studies. A couple of years ago, Alan Joby set up an amazing study to characterize the pharmacokinetics of Dex and Beta in women, and studied different dosage forms, IM and oral, and especially betamethasone sodium phosphate plus acetate. That's the common form given to pregnant women in the US. So this was a partial crossover study in 48 women, and allowed us to characterize most definitively the pharmacokinetics of these dosage forms. So the general pharmacokinetics of the 5 forms that were administered is shown on this slide. So if you look at the bottom, oral Dex, oral Beta, typically Beta has a much longer half-life than Dex. Looking at the top, the same thing happens when the phosphate forms are given intramuscularly. The phosphate hydrolyzes very quickly, but when beta acetate is given, that's a prodrug that very slowly dissolves and hydrolyzes to form betamethasone. So the pharmacokinetics from the mixture of the phosphate and acetate are shown on the top. And it basically has an extremely long persistence time in the body. These studies were carried out with a 2-week period between crossover phases of the study. And betamethasone could be detected 2 weeks after its IM administration because of this very slow release from the beta acetate. Well, this study provided the most definitive pharmacokinetics of these steroids based on the intensity and length of sampling, the exquisite analysis, the extremely careful control of all experimental conditions. One of the things we did was, because of the crossover nature, we could compare the clearances of betamethasone versus dexamethasone in each of the women who had a crossover. It's a fair amount of variability in these normal, healthy women. The typical pharmacokinetics that we saw are listed at the bottom. Basically, as indicated, betamethasone has a much longer half-life than Dex, 12 versus 6 hours, partly because of its lower clearance and a modest difference in volume of distribution, which represents tissue partitioning. We carried out pharmacodynamic measurements on 6 biomarkers. 4 of them are shown here. So blood samples were collected to measure various types of samples in the blood that are sensitive to effects of corticosteroids. So look at, for example, CD3, CD4, the T cells at the bottom left. There's a circadian rhythm in the baseline. You see the numbers going up and down. Then when the steroids were given, you see a drop in the number of cells, a slow return back to baseline towards baseline over 48 hours. And then roughly between 48 and 72 hours, there's a rebound where the cell numbers go up higher than the baseline. So we could characterize these curves with various PK/PD models that we developed in the past. One of the models is shown at the top right. And with these models, we could resolve parameters like IC50, SC50, or EC50 for the steroids. So we could determine the relative sensitivity comparing Dex and Beta, and we could do those in each of the women where there was a crossover. And that's what's indicated at the bottom right, how consistent the IC50 values were comparatively among the women and between the 2 steroids. So the typical IC50, SC50 for our 6 biomarkers is shown on the current slide. But I direct you to the ratio that I report on the right. Basically, the IC50 of Dex is 2.86, greater than that of Beta for suppression of cortisol. So that's what those ratios indicate. Dex is more potent by X-fold, and on average, Dex is more potent by 1.8-fold than betamethasone. So what we generally found was that the longer pharmacokinetics of beta but its lower potency results in the single dose PD profiles that were on the previous graph that look quite similar. Those profiles only differed modestly from each other. They were all the same doses, but comparing the properties of beta versus dex gave us increased clarity on what was happening. Now, on to antenatal use of beta and dexamethasone. I often use this picture of the pregnant lady in previous lectures, and I used to tell my audience that this was the first picture of my daughter, Natalie, before she was born. But she used to resent that, so I stopped saying it. And that's not her mother, so this is not true. But more seriously, World Health Organization and Gates Foundation have made statements that there is insufficient evidence on the safety and efficacy of antenatal corticosteroids in preventing mortality and severe morbidity amongst late-term premature newborns in low-resource countries. So these drugs are used effectively in countries like the US and throughout Europe. But there's uncertainty about how to give and what to give and whether they work well in the low resource countries. It's partly a matter of the availability of appropriate medical help, appropriate drugs, and appropriate care of mothers and infants. IM beta PA, okay, that's betamethasone with the phosphate acetate mixture, is the standard of care in developed countries. But IM dex phosphate is standard of care in low resource countries. So why is that? Well, the beta phosphate acetate mixture, half and half, is an IM dosage form. It's not available in many countries, in undeveloped countries, but they do have IM beta phosphate. The phosphate acetate mixture is more complicated, it's much more expensive. It's not on formularies, but dexamethasone is much cheaper. It's available. That's what they need to give. That's all they have available. But are they using it properly? Does it work in those circumstances? The Gates Foundation wanted to improve antenatal use of steroids in women, and thus have funded a variety of studies trying to develop more effective therapy. So what happens is that there's a surge of cortisol before a full-term normal birth. That results in induction of pulmonary surfactant. It results in final maturation of the fetal lungs and improved lung function after the baby is born. Without surfactant, without complete lung function, infants develop respiratory distress syndrome, and that can cause brain damage. Steroids are given for that induction purpose, but there's concerns about later effects on the baby, later effects on the mother. Hypertension, a number of the common steroid side effects may persist after such therapy. So giving the proper dose, a minimum dose that'll be effective and not have adverse effects, has been a goal of many studies. A very recent study indicates and supports what I just said. The World Health Organization action trials collaborators. So there's these action trials supported by World Health Organization. And look at the background statement. It says there is currently insufficient evidence on the safety and efficacy of antenatal corticosteroids in preventing mortality and severe morbidity amongst late preterm newborns in low resource countries. But later, what they concluded in doing a study of 6 milligrams IM dexamethasone every 12 hours for 4 doses in needful women was a very ambiguous conclusion. It says that the overall trend of effects suggests that the potential benefit of dexamethasone in late preterm cannot be excluded. Yeah, I've never seen such a wishy-washy conclusion. They just were not certain it was really working well. So what I'm going to present next is a manuscript in press in CPT PSP. I just got the galley proofs today, and we're looking at them. So collaborators on this part of the study are Wojciech Kaczynski, Mark Milad, Alan Joby, and myself. Wojciech Kaczynski did most of this data analysis. He can do fantastic pharmacometrics. So our purpose was to assess all available PK data for beta and dex in pregnant women and their fetuses using a meta-analysis approach with a hybrid minimal PBPK model. So by meta-analysis, I mean use all possible information that can inform the model and our analysis. And what we could take advantage of is that there are similarities in structure, molecular weight, log P, protein binding, tissue permeabilities of the 2 steroids that allowed us to share some of their properties. As you'll see, what we've encountered was very rich data for betamethasone because that is the standard of care, but very little data for dexamethasone because its use for this indication is basically exploratory. So we did the best we could. So the literature sources were all of the publications kind of cited here. The full will be in our paper. And we knew of other sources of data. I asked the investigators who had additional raw data for a number of women, and I was declined by 3 sources. One of the sources was investigators in Europe who gave the excuse that their country does not allow sharing of data outside of France. Very frustrating. So there's possibly more to come in this analysis once we can get more information. So our, what we call a hybrid minimal model is pictured here. So what you see in the blue is the part for the mother. It is the same kind of model we used for dexamethasone and many different species, with the addition of blood flow, drug distribution to the placenta. The fetal part of the model is from Zato et al., a recent publication in 2021. It's a more simplified minimal model, basically blood and a tissue compartment, but it also has Zato's placenta part component. So the placenta basically, what one is seeing in the diagram is, blood flow to and from the placenta in the mother QMP in the middle, blood flow to and from the placenta QFP from the fetus to the placenta. So the model gets more complex. I call it hybrid because it's more than our basic model, and it's combining a couple of modeling approaches. So I don't have time to explain all of the equations, but those who look carefully can see that they are and enjoy mass balance, as these models should. They have physiological parameters, the Qs, the fractions, the volumes being real volumes. Everything is accorded the appropriate physiological structure. Some of the physiology that goes into the model are listed here. So it looks like there's a great number of parameters, and there are. The parameters come from recent literature. There have been approaches to building full PBPK models with a lot of information that we borrowed from. We assumed the mother would be at a gestational age of 39 weeks, but the model could be readily tweaked to go earlier. So it's a long list of parameters, but keep in mind, this is a minimal model. It's a simple model. The full PBPK models would probably have 5 times as many parameters because they also have to factor in all of the additional tissues in the body. They have to factor in how everything in the body might differ during pregnancy. Our models do the best they can with the known anatomy and physiology of the term mother and fetus. So here's the beta pharmacokinetics. So Hosak had very rich data after administration of betamethasone phosphate acetate mixture. That's the standard of care. And you see 2 doses were given, the plasma concentration in the mother on top, and the plasma concentration at birth in the fetus in the middle. So the beta PA is the mix of the fast release phosphate, slow release acetate. So you see the terminal phase having a long sort of half-life. It persists a long time in the body. The graph at the bottom is from another source. Again, we used multiple sources of information, of data, and I'm just showing part of it. So the data points are what we digitized from the publication, as accurate as we could do. The curves are the result of our minimal PBPK metamodel fittings. Again, where all information about Dex and beta were analyzed together. And you can see these fitted curves capture the profiles extremely well. What is significant is that the fetal cord plasma concentrations are about 30 to 40% of maternal values. So that can be explained by the role of the PGP transporter in the placenta. What we found for dexamethasone was far more sparse. So here's part of the data. You see some of the maternal pharmacokinetics on top. You see more of the maternal concentrations in the middle. But what you see at the bottom are very, very limited fetal concentrations. But once again, fetal cord concentrations are about 30 to 40% of maternal values. These curves also show the fitting with the minimal model. We could capture these profiles extremely well. Bottom line at the left, there's very little data for Dex. It needs verification. It's hoped that more studies will be done capturing maternal and fetal plasma concentrations when Dex is used to treat women as described. So the result of our modeling is capturing an array of parameters that are characteristic of the drug in this system. So the fitted parameters are in this table. And one can see from the percent RSC relative standard error that the statistics of the fitting was quite good. So I marked in yellow some of the special features. So at the top, we obtained the clearance of Dex, the clearance of beta from this meta-analysis. The mean value of Dex was 26.7. that was nearly 3 times more than what we found previously in the non-pregnant woman, 9.3. For beta, clearance was 8.93. It was a bit higher than what we saw in the non-pregnant women, 6.0. So pregnancy causes an increase in clearance of these steroids. And one needs these kinds of studies because the clearance determines the dose that's needed, among other things. And it means that women are basically metabolizing the drug faster than they would have when non-pregnant. These steroids are metabolized by the liver CYP3A mechanisms. Apparently, this mechanism is markedly upregulated during pregnancy. We accounted for the 30-40% ratios, fetal to mother, with a clearance that is presumed to be mediated by PGP. So PGP is an efflux transporter. And these clearance values that we found, 36 and 42, essentially the same for both steroids. So unlike handling by the liver, the handling of Dex and beta by the transport mechanism is basically producing about the same value. So efflux transporters sort of exist naturally to protect a tissue or an organ against high exposures of drugs. So this kind of transporter exists in the brain. It exists here in the placenta as well. Down at the bottom, we found a rate constant for absorption of beta acetate. So I indicated that it has a very long persistence. We characterized that very long persistence in the non-pregnant women, and a similar value exists here. Very, very slow release. So this gives us some numerical information and insights into how the two steroids compare in their pharmacokinetics in pregnant women. The last part of what we did was a simulation of the World Health Organization recommended dosing regimens for treatment antenatal use of the steroids. So they're all multiple dose studies. The standard use of beta PA is shown in the third panel on the right, where it says common RX. So that mimics the profiles that we were fitting in this from the data that we analyzed. But one can also see the regimens that are used in the ongoing trials of alternative ways of using these steroids. So there's something called the Action 3 trial, World Health Organization sponsorship of clinical trial. And what you see at the top is their utilization of dexphosphate, IM, 4 doses, the higher dose. And then at the very bottom, 2 milligrams, 4 doses every 12 hours. So what's shown at the bottom is with betamethasone. It's sort of a more minimalistic approach in terms of therapy, trying to get down to the lowest dose that will be effective and not have adverse effects. So the best indication is to keep maternal and fetal betamethasone trough concentrations, basically the low concentrations during the first 2 days, trying to keep those concentrations above 1 nanogram per mil. And all these regimens do it. I have a column, it says NB for the trough concentrations of the steroids for these regimens. And they're all successful in doing that. And then we found greater potency of Dex. In the biomarkers that we studied, it's not clear as to what the potency of Dex is in treatment of this antenatal treatment. But if what we saw for the biomarkers holds true for this condition, Dex has a greater potency. It should allow for lower concentrations with whatever doses are being given for this indication. All right. Lastly, I mentioned that a full PBPK model has been enacted for beta and Dex. So these investigators have published a very comprehensive, exacting assessment of the possible physiological pharmacokinetics of these steroids in pregnant women. They examine the same beta phosphate acetate data that we examine, and that's essentially the triangles, the curves on the left. And when they first made predictions, the data were under-predicted. So what was needed to do was optimize the fittings. So they changed their parameters to fit their data. And that's shown on the right. So basically, what are they doing? They're doing what we did, getting the best fitting of plasma data. It's not really fully predictive, but it's a very lengthy, comprehensive, lots of parameters model that ends up on just fitting the best one can with the plasma concentrations. Well, both of these, their assessment and our assessment arrived at about the same conclusions because we're both looking at maternal and fetal concentrations. Ours is a bit more comprehensive because we used all possible data. They used only part of the data that's published because doing this is a lot of work. So it's readily possible to apply full PBPK models, but our argument is, why bother with the unnecessary baggage? All of those additional tissue compartments that are just weighing down the computational procedure, making it more difficult for the investigators, for someone new to try to do modeling of this type. So, my summary. We argue that minimal PBPK models offer better insights into pharmacokinetics than compartmental models. And as I've shown, they're advantageous for meta-analyses and species scaling. Secondly, I've shown that the PK and PD of Dex and beta have been well characterized in various species and in non-pregnant women. And I've also shown that full and minimal models work well for Dex. And we've now shown can be applied to beta. And then lastly, our meta-assessment of the extensive beta PK and limited Dex data in term pregnant women and their fetuses using our model provides a more complete and rational insights into therapeutic options for antenatal steroid therapy. And again, I'm thankful for the support that we received in performing these studies. That will conclude my presentation, perhaps with this last advertisement of our future PK/PD courses in May 2023. I don't know if you do questions in this system.
We do.
Okay.
So we will take questions. Feel free to enter questions in chat or raise your hand, and we will promote you to be able to speak. If anyone has a question on Dr. Jusko's talk. So I will start. So the method you're using for developing the model, the more minimal PBPK model, has you lumping together compartments. How do you determine which compartments are lumped? Is this just based on the fitted data, from a compartmental modeling approaches?
No, well, it is in part. The data tells us how to lump the models. It's basically, one sees typically bi-exponential, tri-exponential, even more complex curves. And the structure of the model says that there's, normally like three compartments, the blood, two tissue compartments. We know from full PBPK models, which organs and tissues typically get highest blood flow that has highest permeability. And the drug profiles naturally put themselves into the compartments where they have rapid excess because of blood flow and permeability. So it's the data naturally working like one expects based on full PBPK models and the properties of the drug.
Okay. So we have a question that's been entered by Irving Steinberg about the efflux pumps. So does the changes during pregnancy that occur in efflux pumps. So does the PBPK model adjust for looking at the dynamic kinetic changes during pregnancy?
Yes and no. Our data were taken, we use published data that were taken from women needing these steroids and where they could take some blood samples. And they're up clearly towards the end of the pregnancy. So the data represent whatever state the women were in when the data were collected. It's possible to deal with all of the anatomy and physiology, to also adjust them for the gestational age. That could be added to these models. They're an element that can be present in the full PBPK models as well. So that doesn't.
Yeah,
but
it's having that data to add to the models, I think, is the difficulty, right?
The thing is, what do you know to inform the model? Basically, how is the transporter functioning, let's say at 30 weeks, 32, 35, rather than 39 weeks? That may or may not be known. It can be assessed in animal studies. It can be assumed, but there's no data to support it in humans. In animals, there would be. Oh, I know. Actually, people have done perfused placental studies as well.
Yeah.
So those could be done more readily. And in our paper, we cite a study that was done that showed essentially identical permeability of beta and dexamethasone using a perfused placental assessment. So if they had placentas from much earlier, they didn't, they could get some information.
Yeah, I believe most of the placental perfusion studies are actually done at term. So I would suspect it's hard to get that data from earlier in pregnancy. Looks like we have another question. So from Dr. Zaidi, you said Dex and beta concentrations in fetal blood were 30 to 40% of the maternal blood concentration because of P glycoprotein, but the PGP expression declines near term to allow more drug exposure to the fetus. So don't you expect higher drug concentrations near term in the fetus?
Oh, that's interesting. Yeah. Well, those concentrations are what had been observed. Perhaps those numbers will change a little bit if one factors in protein binding and free drug. But the protein binding, what we cite in our paper, is almost the same. So I don't know what to expect. It is what it is.
Yeah.
I don't know what happens with other drugs.
Yeah, so Irving Steinberg comments again that methadone's been examined in preemies and full term, looking at PGP efficiency and placental perfusion studies. So that may give us an indication of maybe the P glycoprotein expression activity changes across gestation as well.
Oh, good. Yeah, I'd love to look at that.
Great. Great. Are there any other questions for Dr. Jusko today? If not, we will conclude our webinar and thank Dr. Jusko for an excellent talk. And we look forward to seeing future work in this area. And thank you all for joining our MPRINT webinar today. We look forward to seeing you in the new year. Thanks. Bye.